Good afternoon, everyone. It's my great pleasure to invite Dr. Rasha to our lecture series, which is preparing our learners to be ready for future work. Dr. Rasha is an Emirati physician of emergency medicine and the DIO of Dubai Health. She's also the Vice Dean of Graduate Medical Education at Mohammed bin Rashid University of Medicine. She oversees 37 training programs and more than 600 trainees across various training sites in Dubai. She's also an assistant professor of emergency medicine at MBRU and actively contributes to point of care ultrasound education Middle East. Dr. Rasha completed her residency training in emergency medicine at George Washington University at Washington, D.C., and fellowship in emergency ultrasound at Mass General in Boston. She's also the current president of the Emirati Society of Emergency Medicine. Thank you, Dr. Rasha, for your time. I look forward to your talk.
Thank you very much, Dr. Sadiq Anwar, for the invitation and for the introduction. I am an honor to be here today to be speaking about the use of point-of-care ultrasound in internal medicine among internists. I'm grateful for this opportunity to interact with colleagues. I am going to share my screen, prepared slides, and hoping to inspire you. Don't be overwhelmed by my busy desktop. So the title of the talk, I had a meeting, I think 2 weeks ago with Dr. Anwar, and we both have one passion that we share, is our passion for point-of-care ultrasound. And I was very grateful for him to inviting me today to give and share this passion with everyone here. I don't have any disclosures to actually list out or declare relevant to this topic. But the only thing I want to declare is I am very, very passionate about point-of-care ultrasound and how that affects the practice of medicine and patient care. So just a little bit background of myself. I thought, it would be good. I know it's virtual. I would have loved to have it in person. So I actually graduated from UAE University, where I had the, opportunity to learn from amazing educators and leaders in the field of medicine. I actually was there yesterday for a career fair, and it was nice deja vu going back to the campus where I actually learned now 24 years ago. After that, I did my residency in George Washington University in Washington, D.C., and that was an amazing experience in D.C., very different context. But during residency is where I really fell in love and really believed in the use of point-of-care ultrasound. And later today, I'm going to share with you a few of the cases that I encountered during residency, after residency, and during fellowship. So because of my passion, I thought, okay, I'm going to pursue a one-year fellowship at Mass General Hospital, which is part of the Harvard Medical School group, in the use of point-of-care ultrasound. So there I really learned not just how to perform ultrasound, but how to actually conduct courses, how to manage ultrasound in a department. And really, it made me not just a ultrasound user, but also taught me how to be an educator. And it was an amazing learning experience. So since 2014 until now, alhamdulillah, I'm back in the UAE. And yes, it's been 10 years of practicing emergency medicine, clinically, teaching, as well as, teaching undergraduate, graduate residency, and then also during doing continuous professional development, several workshops. And I will tell you, over the past 10 years, my goal was really to start and spread this skill and knowledge to as many physicians as possible, because I think the practice of using point-of-care ultrasound really have changed my practice, and it will be very hard for me to actually go to a shift now without having the machine there to me as an additional tool to assess my patients. So I just want to get to know the audience in the room. I know this is meant for internal medicine. I just want to see if you can join menti.com. And I don't know if you have another device. I know you're using Zoom already, and use the code that is on the page. I just want to see if you're able to tell me what specialty are you in? Is everyone in the room from internal medicine, or is there anyone else from other specialty? I just want to check if you can log in. So far, I have not, no one's in. But if you go to, so there's emergency, good, internal medicine. I saw someone wrote in the chat, emergency. Any other specialties? Wow. So almost, okay, nephrology, internal medicine. Awesome. Trauma surgery. So there's a good diverse group. And this is important because I want to try and make sure that the context of my presentation will be applicable to the audience in the room. So I am pulmonary, excellent. So there's a good radiographer. So that's very good, but we have to also make a disclosure that when I start talking about the use of point of care ultrasound, pathology, awesome. So I'm very happy. This is a really great diverse group of people who are in this presentation. So next is, what is your role in your clinical practice? Just wanted to see the audience and just to get to know what level do I gauge to and who am I talking to be helpful. So good number are consultants, there are residents in the room, and there's a fellow. So, okay, this is good to know. Thank you for answering, for whoever is actually responding. I think this is very important for us to know who's here. We have two others. Sorry, I maybe missed other roles, but it's good to know. So majority are consultants, good number are residents, and some fellows, and two others. And then, do you currently use point of care ultrasound in your practice? So that's another thing, because it would be important to see. Maybe we can get hoping to so okay, so there are three in the respondents who actually use it, while the majority, if I say at least from the respondents, are not using ultrasound. So I'm hoping okay, good, the number of using is going up, but I would still say 50% still, I mean, the only 50% use, the rest really don't use. So we need to see how we can actually increase, especially if it is relevant to your clinical practice. And then, do you think you should learn or want to learn? So that's another thing. So that's awesome. So I think, so that from what I see, there is some buy-in. People really feel they want to learn ultrasound. They're still not using it. So this is what I'm hoping to achieve by the end of this presentation, is to try and give you reasons and share with you the evidence of the practical use of point of care ultrasound in the clinical practice, and hoping to also share with you some insights. So this is actually a case that I saw, but this is for me a reminder, why do I do what I do? This is a patient, this is actually from the patient's Instagram, not me. And this is a patient who came in the midst of COVID, right around I think the second wave, who came in triage, who was hypoxic. Clearly, she walks in and she looks very, very hypoxic, and everyone thought, okay, this is COVID. Obviously, she was so disoriented that she's not able to give good history. So we did our resuscitation in ABC, and you see one of the most gratifying things, you see, I was taken to resus. Dr. Rasha started looking after me. She did lots of discussion about my case, x-rays, ultrasounds, but I tell you, this is a patient who came in the middle of COVID and hypoxic. Everyone was saying, this patient has COVID. With a little bit of a history, you find out that, oh, she recently had a plastic surgery, abdominoplasty. And I was like, okay, could this actually be massive PE? And I look at the heart, and you can see a clot in that heart. And that made a huge difference in our management, because the way we will treat COVID and how, what we will do would be totally different from someone who's having massive PE and obstructive shock. Obviously, her case was a little tricky because of the recent surgery. TPA was a challenge. So we were, alhamdulillah, able to successfully get her an embolectomy, and she did really very well. But I'm blessed. This is actually one case that, and I'm ever so grateful for the so many different cases that I'm able to make a difference. And I think there's nothing that can inspire physicians more than real cases and how this makes a difference. So I'm gonna just stop sharing my Mentimeter and share my slides. So I decided to call it point of care ultrasound, really a game changer in the clinical practice. So what I will cover is why use point of care ultrasound, especially, I think many of you are seasoned, you're consultants in your field. If you want to adapt this, why should you adapt it, and what are the applications? Second, using it, what are the available specialties that use it? Are there specific specialties? It's applicable to everyone. This room is diverse, so I'm gonna try and inshallah tailor it to everyone. And then I'm going to talk specifically about Mohammed bin Rashid University and the point of care ultrasound program that we were successfully able to launch in 2023, in case anybody's interested. So why point of care ultrasound? We as healthcare providers, obviously, and I just want to brief you, you will hear point of care ultrasound referred to with other names: limited, focused, bedside, clinician performed, POCUS. So these are all names refer to the same thing. It is actually the use of ultrasound real time at the patient's bedtime for specific applications. We as healthcare providers obviously assess patients by taking history, examining them, ordering a bunch of tests, including labs, ancillary tests, ECG. But we rely heavily on imaging. And our colleagues from radiology, I think some are in the room, can tell you that we really use all sorts of imaging in helping us in the diagnosis. So X-rays, ultrasound, CT. We know that ultrasound is one of the tools that we actually use. Now, the difference ultrasound compared to other, I think everyone's familiar, especially when you use it at point of care, it is portable. It is cost effective because you actually can do it at the bedside, repeated, and its cost is probably different than the other modalities. It is dynamic. That means you can actually repeat it on the go, especially if the patient's condition is changing during your assessment. In terms of radiation, definitely you're exposing your patient to less radiation when you use ultrasound comparing to other modalities. The time to get this study performed by your good self at the patient's bedside is quick because you're going to grab that machine and do it at the patient's bedside. The limitation of ultrasound is that this image quality is dependent on the operator. The operator is who is going to perform that ultrasound. And that is when you compare it to other imaging modality, it's quite limiting. And that's where training, education is extremely, extremely important. Now, I want to emphasize that point-of-care ultrasound does not replace comprehensive ultrasound. And what I mean by comprehensive ultrasound is the one performed in the radiology department by our colleagues from the ultrasound technicians and radiologists. Obviously, the format of ordering is very different. When you do a comprehensive ultrasound, you place an order on your electronic medical system. The technician will perform it. The radiologist is going to interpret it and, report it. And then whether it's same position, depends how busy your ultrasound department is. Sometimes I'll tell you in my shop, it can be sometimes I change shifts and my colleague will actually receive the results and integrate these findings in patient care. However, in point of care, you are the person, you order yourself to actually take that machine to the patient's bedside, you perform it, you interpret your findings, and you integrate it into the patient's care. So the flow is different. However, it's very important to understand that for point of care, you're answering very specific dichotomous question. You are answering very specific questions that with an answer yes or no. So in a patient who you think might have ascites, you do that ultrasound, you look, is there ascites? Yes or no? You're not going to go and quantify the liver or all of that. That's done by our colleagues in radiology. They have a comprehensive protocol that they go through and they report on. And you see the report is very structured. It's actually very methodological that it goes through the same sequence. So I just want to highlight and emphasize, you do not replace the comprehensive ultrasound. You do point of care for very specific questions, and you want to try and answer that question with yes and no. So in trauma setting, when you do your ultrasound in trauma, you're trying to answer one question. Is there free intraperitoneal fluid? Yes or no? I'm not going to go and look, is there splenic injury? Is that hepatic injury? So that's not the purpose. And I think if we start by highlighting that early, it's very important because that's a limitation of ultrasound. But it's important to understand and distinguish how different point of care ultrasound is from the comprehensive ultrasound. Obviously, the setup is different, and everything else, even the machines. Our point of care is usually compact machine. The image resolution might not be as good as the comprehensive ultrasound and everything. Just a little bit history about point of care. So point of care is not new. So it started in 1999. So we are almost now 25 years later when there was a resolution that passed to allow physicians to use ultrasound within their clinical scope. Because at that time, there was a debate. Ultrasound should only be used by radiologists. However, the obstetrician were using it, the cardiologists were using it. So they defined this resolution to make sure, and it basically says that physicians can use it, but within their clinical context, understanding the limitation and the purpose of using it. And since then, and you would see emergency medicine, critical care has been the leads in the use of point of care ultrasound in the clinical practice and education. So I'm just going to walk you through the journey. So in 2001, this is the American College of Emergency Physicians. They identified what are the ultrasound applications. So they said, okay, emergency physicians should learn about trauma, emergency echo, the use of ultrasound in first trimester pregnancy, identifying abdominal aortic aneurysm, gallbladder, renal, and then procedural guidance. And every couple of years, so 7 applications at that time, they said every emergency physician should learn. And at that stage, they started including it in residency training. 7 years later, they updated that list and they made, instead of 7, 11 applications. So they added at that time DVT, soft tissue, ocular, and thoracic ultrasound. And since then, the number of applications is increasing. This is definitely talking about, so this is 2016, you see the list is only growing. And now 2024, it's almost 8 years later, the list is only growing. So, and this is from a paper published in the New England Journal listing the various specialties that use point of care ultrasound for different reasons. And you will see a lot of these specialties are listed here. And this is paper showing you, so this is where the 1999 AMA resolution, and then since then, so before this, it's just OBGYN, cardiology, and radiology were using ultrasound. And after that, you would see they start picking up, and since 2018, there has been huge use of point of care ultrasound. And I think now with the AI actually incorporated in many of these machines, it will be definitely adapted at a wider scale. So this is a protocol for the use of point of care, for example, in internal medicine curriculum. So they identify the different applications that can be taught for internists. So for example, GU, DVTs, lung, soft tissue, procedural guidance for central line, thoracentesis, paracentesis. However, I think this is a more comprehensive list. This is listing all of the various applications that can be used within the context of internal medicine and for what reasons. And I think definitely if you do acute care, use of point of care ultrasound will really make a big difference in your clinical practice. Now, just to let you know, point of care is also being used not just in the hospital. This is pre-hospital applications in the paramedics field, as well as in the wilderness. So this is in the high altitude, in the mountains. They look for high altitude pulmonary edema. They look for high altitude cerebral edema signs using point of care ultrasound. Obviously, in the UAE, the space is something, you know, as a UAE is interested in learning about. So when I was a fellow, we were helping NASA to implement a project on using point of care ultrasound in the space to look at how elimination of gravity affects the spine. And so it's not just in the hospital or in the pre-hospital, and also all patient population, such as pediatrics, as is big, and it's the use of point of care is growing in the field of pediatrics and neonates. And then finally, medical schools. Many medical schools actually incorporate point of care in their curriculum. So the future doctors will graduate having had the experience and knowledge and skills of using point of care ultrasound. So with this, I just wanted to really, summarize that point of care is used in almost all specialties: primary care, internal medicine, emergency, anesthesia, critical care. So, and I hope that, everyone will try and go and back to their specialty and see how can you use it. I saw some of the audience in the room are from nephrology. So AKI, the use of point of care, and I think Dr. Anwar can vouch to that. There's a lot of protocols on how to use ultrasound in all sorts of applications. So this part of my talk, I'm going to talk about several cases. And these cases, I think nothing makes us more excited than real cases that I've actually went through. So 58 years old male who presents to the emergency department with dizziness, clearly very sick, hypotensive, bradycardic, and obviously your differential diagnosis for this patient is very, very long. Just to let you know, this patient was in the ED yesterday and signed to leave against medical advice and came back. At that time, the patient was feeling weak in the ED, but his vitals were stable at that time. So this is a bedside ultrasound, and you're looking at the heart. So this is a parasternal long view of the heart. And so I'm just going to give you a context. This is the left ventricle, and this is the right ventricle. And for the non-cardiologist in this room, what do you think of this ejection fraction? This is not a happy heart. This is a very poor ejection fraction. You can definitely see this patient is not, the left ventricle is not, contracting very well. And there's a large pleural effusion on the left side. Same patient, but a different view. This is an apical 4. So this is the left side of the heart, the right side. This is AICD wire. So this is how a wire will look like. Again, you can see this patient has very, very poor ejection fraction. And so I actually wheeled in the ultrasound immediately because this patient looked very sick. And looking at this, evaluating this patient's cardiac contractility, and this is the inferior vena cava. So normally the inferior vena cava should be small and collapsible with respiration. Clearly this patient's inferior vena cava is not collapsing. So in this context, with this patient coming in bradycardic, hypotensive, definitely he has an IAICD in the past. He has history of coronary artery disease. So what my next intuition, putting it all together with this ultrasound findings of the heart and the IVC, there was a long list of differential diagnoses. Could this be septic shock? Could this be this patient be a hypovolemic shock? But looking at this and we put it all together, this is definitely concerning for patient in cardiogenic shock with very, very poor ejection fraction. And we called, our cardiology colleagues. In the initial impression was like, no, I think this is sepsis. This patient needs fluids, this patient. But, I sent the images of the echo. And alhamdulillah, they came, we put the patient on inotropes and support, and we were able to tailor the management instead of fluids to starting this patient early on pressors and pressor support to be able to help with the blood pressure. Patient, alhamdulillah, eventually did well. And the cause of the cardiogenic shock was further coronary artery disease. But this is very different than the, your reflex strategy of giving every patient with hypotension fluids. Because at this patient, if you actually give them fluids, you will 100% put them in pulmonary edema. So moving on, so this is case number 2. This is a 23 years old female, and this is actually, I remember during residency. Came in unresponsive. They called us, there was CPR in progress. The estimated time of arrival is 5 minutes. So as a senior resident on shift, I remember, young female coming unresponsive. There are very few differential diagnoses that we think of. Toxicology, at least when I was in DC, was very high on the list. Next, PE, because DC is a very popular destination, whether tourists, so people from all around usually used to come. So we saw a lot of tourists. So PE was also high on the list. Third was obviously ectopic pregnancy, because the young female in arrest. So all three differential. So in preparation, we wheeled in the ultrasound. We said we're going to prepare to ultrasound this patient as soon as this patient comes. Obviously, ongoing ACLS care was there. So luckily, the patient had ROSC on arrival. And this is the first thing we see when we scan this patient. So just to orient you, I'm actually evaluating the right upper quadrant, left upper quadrant of the abdomen. This is the kidney, this is the spleen, and you see there is large amount of free fluid in this. This is positive for fluid. Now in a young female, so this is the right upper quadrant, this is the liver, this is the kidney, and you see there is free fluid also in the abdomen. In a young female, finding this fluid, obviously fluid can be blood or ascites, but in a trauma setting or a setting that we don't know, we assume it's blood. So this immediately, obviously we started the massive transfusion protocol. The patient was started on tranexamic acid. And we called our general surgery as well as the OBGYN because we didn't really know what happened, although there was no really clear history of trauma. So putting it all together, this patient has a positive trauma, a positive free fluid in the abdomen. To be honest, this patient eventually was diagnosed with a spontaneous splenic artery rupture, which is very, very rare. And I will be very honest, I didn't know what the diagnosis is, and I don't really want to know. I know this patient is in shock. I need to identify what type of shock. Why did this patient actually code it? She's only 23. And the fact that we had a positive FAST, I know that this patient was bleeding from somewhere, whether it's a ruptured ectopic or a very unique or rare aneurysm, was beyond my scope in the emergency department. But we were able to engage with the experts who were able to collectively, and they were colleagues. They went both to the ward together and were able to figure it out. Alhamdulillah, the patient actually did well. Moving on. So this is a 41 years old female, no history of lupus, who comes into the emergency department with chest pain. And these are the vital signs. So this is when I was a fellow, and we were a very busy emergency department in downtown Boston. And I remember it was so busy. So I had to supervise so many different resident PAs that during the shift. And I remember probably maybe an hour and a half later, I come back to the resident and I was like, okay, what did you find? I had a senior resident with me. And she was like, yeah, we got the labs, patient's sinus tach, and we're waiting for the rest of the lab. And this is the chest x-ray. And as soon as I saw this chest x-ray, I was like, oh my God, I feel so bad for not wheeling the ultrasound earlier. I know I was busy, but have I had the chance to ultrasound this patient early, probably will be able to know why this patient is having chest pain and the hypotension. So this is the echo of the patient. So what you see here is this is the view of the heart, and you can see this black fluids around the heart. So this patient had a pericardial effusion and early signs of tamponade. So as soon as I saw this, it was concerning, because when I saw the history and then resident presented, my immediate impression was probably this patient is some sort of sepsis. We need to go and try and find out what is the source of this infection. But this was not high on my differential diagnosis. So this patient actually went to the cath lab. They were able to drain 700 ml of fluid from around the heart. So luckily, and the management, obviously, alhamdulillah, we already gave her some fluids, which would have helped both, because this, we know when the patient has tamponade, they're usually they have obstructive shock, so they're preload dependent, and finding this really supported us to take the patient. So when we do bedside ultrasound, we ask ourselves, especially for echo, we ask ourselves very specific questions. Remember, you're not replacing the comprehensive echo. So you want to look for signs of RV strain in patients with suggestive history of massive or PE. You want to look, is there pericardial effusion in patients? The other thing, what is the global left ventricular function? And finally, in patients with cardiac arrest, you use ultrasound to look for evidence of organized cardiac activity. So we ask ourselves when we do the echo very, very specific questions rather than comprehensive. We don't actually do any measurements. It's not quantitative, it's more qualitative. So you will have a global assessment rather than measuring the ejection fraction. Okay. So moving on, this is a 70 years old male with a history of heart failure and known heart failure with ejection fraction of 35%, now presenting with fever, altered mental status. I'm sure all of you have, see these patients, especially in the medical field, in the emergency department. Clearly, this patient is in shock. Now, the question is, most likely, this patient has some sort of sepsis. Where is this the source of infection? We have to look for. So now the question, the nurse will, and this is as a team, we need to decide. We know this patient has heart failure. Should I give patient fluids or not? And one of the easiest thing that you can do is to assess the patient's inferior vena cava. So this is the patient's inferior vena cava. You can see that this is the IVC draining into the right atrium. This IVC is small and collapsible. So if you see a small collapsible IVC, tells you that this patient probably will have room for you to give this patient fluids. Until the other thing that you can look at is the lungs. So this is a view of the lungs. This is the rib, and that's a rib, and this is the pleural line. And you don't see any B lines. B lines are suggestive of fluid in the alveoli, suggesting that this patient has some sort of alveolar or interstitial fluids. So with a clear lungs and a collapsible IVC, I feel very confident giving this patient fluids, even with an ejection fraction of 35. Obviously, I'm going to do it in smaller increments, more frequent boluses, but small, and frequent reevaluation. So this is just side by side. This is a small collapsible IVC, while this, you see, this is a plethoric IVC with minimal respiratory variation. So you see it is distended with minimal respiratory variation. I just want to caution you that if you see this, it doesn't mean this patient will not benefit from fluids. It's just you're not sure. However, if you see this, you know this patient will probably be fluid responsive. Moving on, this is a 69 years old complaining of epigastric pain and vomiting. This has been going on for 4 hours. Again, this patient is not well. This patient is hypotensive. And, I'm looking at the epigastric area, and you see this huge circular vessel there. So this is an abdominal aortic aneurysm, and you can see that there is intramural thrombus. I cannot tell you how many times I actually found it by incident. And it makes a big difference in the patient's care because we know these are high risk. I just want to emphasize that ultrasound, at least point of care ultrasound, will not tell you if this is ruptured or not. And you can actually just answer, is there an abdominal aortic aneurysm? Yes or no. And you can, look at this. So some of them, the patients will tell you, oh, yes, I have a history of aneurysm. So you just have to put your findings within the clinical context. Another case, 58 years old, presented with a syncopal episode. So she was visiting the city, and you can see the patient is clearly say hypotensive, tachycardic, also hypoxic with tachypnea. So this patient is definitely not doing well. So while we started resuscitation, taking the history, trying to evaluate her more, I wheel in the ultrasound, and this is what you see. So just to give you a few seconds and orient you. So this is an apical 4-chamber view, not the best view, but enough for us to actually assess. This is the left side, and this is the right side. So this is the right ventricle, left atrium, right atrium. And you can see this. This is an intramural thrombus that is actually floating between the right atrium and right ventricle. And going back, this patient actually was visiting the city. She was out of town, so recent history of long distance travel, and was complaining of leg pain. And so this is a parasternal short, so another cardiac view. And you see that this is the right ventricle. It's actually the intramural septum between the right and the left is pushed towards the left, because with massive PE, the pressure on the right side of the heart goes up. So the right ventricle will become larger, when normally the left ventricle in a normal heart should be larger than the right side. Now, we know when to diagnose massive PE, there are some implications, especially if you're going to thrombolize this patient. So another way is to look for the DVT, because most of the time we know the source is a DVT. So this patient, obviously, apart from seeing the thrombus in the heart, you can actually clearly see the thrombus, and this is in the common femoral vein. You see this vein. This is the vein, common femoral vein, the greater saphenous vein. There is intramural thrombus and it's not collapsing. This is the artery. So with pressure, the artery is pulsating, but the vein normally should collapse. So this is what a normal vein should look like. When you push, it actually collapses. But here it's actually not collapsing, and this is the left side. And the same thing with the popliteal vein. The popliteal vein is not actually collapsing. And this is what a normal, and the left side was the normal side. So when you push, the popliteal vein is on top of the artery, it usually collapses. So with this, putting the history together, patient has obvious DVT and has an intramural thrombus. We were lucky we are in a center where you actually have a team that does thrombectomy. So this patient went for thrombectomy and did well. But sometimes you need to push TPA, and with limited resources and a hypotensive patient, getting a CT scan might be a challenge. So you might need to use your ultrasound to make that decisions. Moving on, so this is a 19 years old female. Again, this is actually during residency, who came in with shortness of breath. So she was brought by ambulance from a long-term facility. She's unfortunately on tracheostomy. She's bed-bound. And according to them, she was having difficulty breathing. So they called the paramedics, and this is what they found. Patient is hypotensive, tachycardic, tachypneic, and hypoxic. And despite all efforts, the patient remained hypoxic. The paramedics were trying to bag her with a bag valve, and she was still. So what I did is actually I scanned as soon as she came in. Obviously, RT was there. We're suctioning the trach. Nothing is really coming out. We ordered a portable chest X-ray. Obviously, I was there. I was the resident on, and I look at the lungs. So you see, this is the rib, and this is the rib, and this is the pleural line. And you can see clearly that the pleural line is not sliding. So in the right clinical setup, and this is actually, this is the right side and this is the left side of the patient. And you can see both sides, the pleura is not moving. So I was like, okay, there must be something really wrong. Either my scanning technique, she can't really be having bilateral pneumothoraces. So we got the stat chest X-ray, and this is what we find on the chest X-ray. So in fact, she had bilateral pneumothoraces, and I think this is probably from the aggressive bagging that the paramedics had from the initial presentation. So at that time, because I was like, there's no way the patient has bilateral pneumothoraces. So we put in a chest tube bilaterally, and the patient, get better. So just to show you, this is what a normal lung sliding looks like. So this is the rib, and this white line is the pleura. And normally with respiration, the pleura will be moving. And this is what absence lung sliding is. In the right clinical context, this is suggestive of pneumothorax. There are some conditions that can cause false negative for lung sliding. For example, atelectasis, history of pleurodesis, all of these, because in these cases, the visceral and parietal pleura will not be sliding. So it gives you a false positive for no sliding. So I think the investment of using ultrasound really in patients with shock, patient who becomes unstable, is vast, because you can use ultrasound in identifying the potential causes of shock. So we know that there is this hypovolemic shock. So what you can see with hypovolemic, you can see if there's any free fluid in the abdomen, maybe the source in a ruptured abdominal aortic aneurysm, looking for the AAA. You can assess the IVC and see if that IVC is collapsible. And you will see the heart will be hyperdynamic. So the left ventricle will be contracting. Apart from being fast, even the volume will be hyperdynamic. You can look for cardiogenic shock. Again, you can assess the left ventricular function. You can look at the IVC. So remember, you see most of the time, you will need to use multiple applications, not just one. And a lot of the time, you will put all of this together within the clinical context of the patient's presentation. So obstructive shock, you can find for signs of tamponade, massive pulmonary embolism by looking for RV strain or for the source, such as DVT and pneumothorax, and distributive shock. So you can also look for the left ventricular function and the IVC. So this is just a brief flavor of some of the cases that really got me excited and really passionate about point of care ultrasound. So since I came back from fellowship in 2014, I've conducted so many different workshops, alhamdulillah, and it's been an amazing journey. But workshops are really not enough when you talk about a skill like this. I was fortunate enough, I was the program director and a core faculty in SKMC. And alhamdulillah, we were able to incorporate this in the emergency medicine residency training. But we know that that's not enough because it's only going to be for the active residents. So my passion was really to start a point of care ultrasound training. So far, we don't have what we call the clinical fellowship, similar to North America. But at MBRU, we were able to start two different programs. The first program was the fundamental of point of care ultrasound. And this year, the first one we launched in January 2023. And the second, in the pediatric point of care, we launched in this year, January 2024. So right now we have two of these programs going on. And the reason is because, like I said, ultrasound is a skill that really needs practice. And just attending one workshop that is 8 hours or 16 hours long is not enough. So this is a 1 year, it's a hybrid program, and it's basically that goes and will take you through. You can scan the QR codes and you can look at the websites, what applications that you teach. And this is just a general outline of the program. You do a lot of the theoretical knowledge. And I think there are three important things you need to know when you learn ultrasound: knowledge, skills, and how do you incorporate your findings in your clinical practice. I think in general, knowledge is the easiest part. Many of you probably have not scanned before, but have able to look at the videos I showed you today and interpret them. So the knowledge part is done through an online 6 weeks module that the participants go through. And then you will come in for the hands-on skills. There you will be introduced to all of these applications. And then you go to your clinical practice and you really need to practice. And evidence show in order to be competent in an application, for example, say I want to be comfortable, and this is the diagnostic. For example, you want to feel comfortable evaluating the heart. You need a minimum of 25 to 30 echoes that you actually do and review and interpret to feel a little competent with the basic applications. So that's what these clinical practice, they spend a lot of time collecting cases, uploading them on the platform, and they get the feedback from the faculty. They come back to another 2 days of a refreshing skill refreshment course, and then they will have to complete a portfolio of a total of 130 scans of the various applications. Finally, they'll do a knowledge assessment and they complete the program. The fundamental programs go through different applications: introduction, basic physics and knobology, lung ultrasound, cardiac ultrasound, trauma, first trimester, and abdominal aorta. While the pediatrics, the last two applications are different. So the pediatrics covers soft tissue and intussusception. So it's an online, if anyone is interested, happy to share more information. So just take home points from the presentation. The use of point of care ultrasound is really well established. And I think the future of practice of medicine, students will graduate from medical school having known and have some skills on using ultrasound. Really, it improves patient outcome, but you really must know what are your limitations and what are the clinical questions you're trying to answer using your ultrasound. Education and training is essential because especially if you will make decisions based on it. If you just want to go and scan and learn and you will order something else, that doesn't really have a big impact. But if you're going to do decisions based on your ultrasound finding, you need to make sure that you're competent and comfortable with the training and the skills that you have obtained. So these are my references, and I'll be more than happy to answer any questions. Thank you.
Thank you, Dr. Rasha, for that excellent talk and giving some real life examples how point of care change immediate patient management. I think so one of the reasons why ED adopted point of care ultrasound is because your margin of error is so small and the timeliness of care is so important in ED. Unlike in internal medicine, where we have the luxury of time and a luxury of all the results being available. But gradually, even that luxury is going away because the pressures on the hospital to reduce the length of stay, reduce costs, and of course, the patients who don't have insurances in the system. So, could I ask the people in the audience if they have any questions, if they could put that in the chat box, and I'm happy to put it to Dr. Rasha. Dr. Rasha, one of the reasons I invited you was, of course, most of our residents are young women, and they want to see a role model like you who's doing this. So it kind of inspires them into picking up any skill, not just point of care ultrasound. Historically, in healthcare, education was you do what you do at the fag end of your career. You retire into education. But now I see young people like you leading education programs. Presumably, you have trained into this. Could you just tell us about how to become an educator? What kind of skills you have to learn?
So thank you so much, Dr. Sadiq, for the question. And 100%, I think we are all trained clinicians, right? We are trained how to take care of our patients, do this, history, physical. But like you say, many of the current or previous educators were doing it part of the retirement plan and passion. And you see many of people do education part of something that they actually love and they're passionate about. But there is science behind it. And that's the important part, is how to be an educator and especially the clinical educator. So there are so many options in your career path, especially for young people early in their career. There are several routes that you can go. There are medical education fellowships that you can actually do. When I did my ultrasound, I actually did my point of care ultrasound fellowship, and I did some training in medical education, and I did a diploma in medical education. But you can do diploma, you can do masters, you can actually do a clinical medical education fellowship, especially if you're interested in medical education. So for me, because of my passion of point of care ultrasound, naturally you need to be an educator, because big part of what we do in our fellowship is education. But they taught me the science behind education, little bit theory, like educational theory, the philosophy behind that, but also how do you bring practical and make clinical education very, very easy. So definitely I would encourage, if someone is considering medical education, there are so many different options. There are diplomas, masters, in medical education, or clinical fellowships. If someone is also training and they are early in their, still in residency, I would strongly encourage you to get involved in preparing for academic days, whether at a chief level or just as a resident, because that's a great opportunity. So ask your program director if you can get involved in organizing your academic activities or supervising interns, students that or residents from other departments that when they come and rotate, because this all will increase your likelihood of getting accepted in these programs, whether it's fellowship in education or master's and diploma, and you will explore that passion, because I think, especially when it comes to education, you really need to be passionate about it and to pursue this career. So during residency, I think you have ample amount of time to start it. You can start as small as, I'm gonna help with our academic days. And then definitely I would encourage pursuing proper training in medical education, because like I said, there is science behind it.
Thank you very much for that. Actually, I mean, I cannot attest that to your statement more. And I keep challenging my residents. You can't suddenly become a pilot now or an architect. This is your career till you die or retire. So why aren't you planning your career the way you plan your finances, your travel holidays? And definitely, if they want to be an educator, they have to look at role models like you. I know MBRU has an educator course as well. Am I right?
Yes. So we actually just launching the Masters of Medical Education and a Diploma of Medical Education. And this is newly launched. But also there are educational courses, just certificate courses that you can go online and learn.
Thank you. And there's a question from Dr. Hindasi that how can we join the POCUS program? I will share that link on that. I think Dr. Salma had a question, but she didn't type it. Anyone else has a question? 1 second, let me have a look here. 1 second. No one, no other questions, Doctor. Thank you very much. And I think so that's been a brilliant talk actually. I think Dr. Salma had the same question. Okay. Thank you very much. And I will share the link of your course to our residents, because the training I'm doing is mostly bedside clinical teaching, but for credentialing a licensure, having a formal course which Dr. Rasha and her team are running is important. And
And I think, Doctor, that's another offer that I can do for the I am program director. If there is any chance or curriculum, we can build a curriculum for the residency program together. If there are enough manpower to help lead it, I'm more than happy, because I think it's also important to have that sustainable, manpower to make sure the supervisors of that training. So I'm more than happy to collaborate with SSMC, the program directors, and see if there's something, especially that you have already a good emergency medicine residency, and see how we can help collaborate both IM and EM at SMCC to make sure that POCUS is trained, because the residents are the driving force. If they wheel that machine in, it will be used.
Definitely a question from one of our pediatric colleagues, Dr. Ahmad Al-Mazmi. Can you share us the application of POCUS in pediatric population? So maybe what I can do is I can connect you both so you can take this conversation forward. I presume he's looking to integrate that in his program. And definitely there's a curriculum already made. I have already made a curriculum. What I am struggling, Dr. Rasha, is to reach the Department of Health so that they can mandate it. Because of course, you are lucky that you have Alawi Al-Sheikh running your academic healthcare system, who is a visionary leader. So we need someone like that. So if you can use the offices to convince our Department of Health, that would be great, because all the program directors are aligned in Abu Dhabi that they need to bring this, but we need some FTEs and some money sanctioned from the top. Thank you very much, Doctor.
Absolutely.
Thank you. And have a nice day, everyone, and appreciate you all joining. Thank you.
Very much.
Thank you. Bye-bye.